Okay, so we're finally at endocrine pathology. Uh, there's a lot to talk about. Within the first 2 pages, actually, there's a lot to talk about. Um, it gets a little easier after that, but this is definitely the main emphasis of endocrine in first aid, your adrenal gland, right? Because endocrine is all about the adrenal gland here, because your other glands are pretty easy to manage. I mean, there's going to be a lot of talking about the thyroid gland as well, endocrine and thyroid. That's really all that's going to be happening in pathology. But the other glands, like your sexual glands, they're going to be discussed in reproductive. A lot of the renal stuff is in renal itself. So we're really just going to be talking about the adrenal glands and thyroid and parathyroid, and then men's syndrome, stuff like that. And that's all that's getting covered here. And I think it's a nice breakdown, because that way it allows you to really, divide things up and then pay special attention to each thing one by one. So we're looking at Cushing right now. You have to remember there's a lot of things that are Cushing syndrome, but Cushing disease is one thing. So make sure you catch that. What is Cushing disease? When something's called Cushing disease, that's really only referring to ACTH secreting pituitary adenoma. Alright? So pituitary adenoma that has excess ACTH secretion, that's Cushing disease. So let's take a look at Cushing. Cushing is basically excess cortisol due to any reason, whether it be exogenous corticosteroids, adrenal overproduction, or lung cancer. Pituitary adenoma is the Cushing disease, right? So you can see all the different reasons you could have high cortisol in your body are listed here. You could either be taking exogenous corticosteroids, so something like prednisone, etc. Now, if you're taking a lot of exogenous corticosteroids, your own ACTH is going to be low, right? You can see that because of negative feedback. ACTH is going to be low in this case scenario, and you're going to have bilateral adrenal atrophy because your own adrenal glands aren't working, right? Just think of your adrenal atrophy concept like muscle atrophy. Right? Just think of it like muscle atrophy. If you have paralysis of your muscles, they will atrophy because you're not using them. The same thing here. Since you're taking exogenous corticosteroids, right, you're not going to be using your own adrenal glands, so both adrenal glands atrophy because there's no ACTH. Right? If you had ACTH production, the ACTH would go to both adrenal glands and they wouldn't atrophy because they'd be doing work. But the work isn't coming from them here. Right? This is the most common cause, so you should really understand everything you're going to see in it. So this is anyone that's been taking exogenous corticosteroids for whatever reason. Generally speaking, if someone is taking exogenous corticosteroids, they probably have some kind of autoimmune disease for which they need it. Notably, for step 1, maybe lupus, right? But it could be anything. Think of anything that's autoimmune. We saw a couple things when we finished cardiovascular right now too, especially with the vasculitides, right? Like for example with, which one was that? The giant cell temporal arteritis. You have to give prednisone for that, right? So that's just one example. When we get to MSK, we're going to see many examples of reasons you need to take prednisone. It's usually for musculoskeletal skin disorders and stuff like that. Then you have a primary adrenal adenoma, right, or hyperplasia or carcinoma, any of these things. The hyperplasia kind of encompasses what we just looked at with the congenital adrenal hyperplasia. That also falls into this place. However, there's a difference. Do not take congenital adrenal hyperplasia into this scenario at all, right, because there's very low cortisol production in a congenital adrenal hyperplasia. We saw that, right? When we finished all our CAHs, we noted that the only things that ever can be elevated will either be aldosterone or androgens. Cortisol is always low. So every Cushing question you get will always try to trick you into picking one of your congenital adrenal hyperplasia answer choices. Don't do that. Do not do that, because you're not making any cortisol in a congenital adrenal hyperplasia. Right, for whatever reason, there's just no, because you can't. The enzymes that are supposed to make the cortisol are always going to be missing, so you're never making any cortisol in that scenario whatsoever. So this hyperplasia is just a unique hyperplasia that has nothing to do with the CAH stuff. Right, so primary, and it's primary. It's literally because it's just hyperplasing by itself. So you have basically a cancer of your adrenal gland, and that one adrenal gland that's cancerous is making too much cortisol. That makes sense, right? So now, because your cortisol is coming from the adrenal gland by itself without a negative feedback thing, you're once again going to have low ACTH, right? Because all that extra cortisol is giving negative feedback to your brain, to telling it to stop making CRH, stop making ACTH. And you also end up getting atrophy of your uninvolved gland, right? Because remember, anytime you don't have ACTH, you're not signaling your adrenal glands, both of them. If you're not signaling both your adrenal glands, they're going to atrophy. And that's what happened in exogenous corticosteroid use. Here, one adrenal gland is doing all the work, so you don't have any ACTH. So ACTH won't be signaling the other one, and that one that's not doing any work, the normal adrenal gland, is going to go ahead and atrophy. It's pretty much just going to end up dying because it's not being used. The last one here is your last few reasons you can have high cortisol. You can have Cushing disease, which is a ACTH secreting pituitary adenoma. You could have cancerous ACTH secretion from small cell lung cancer or bronchial carcinoids. And all of these scenarios are going to lead to bilateral adrenal hyperplasia. Why? So in this case scenario, what's happening is you actually have ACTH. Now you have high ACTH, either because you have a cancer that's releasing a lot of ACTH from the brain, or a cancer that's releasing ACTH from a very unorthodox location like your lung. Right? This is an unorthodox location. Your lung should not be able to make any ACTH. Either way, all of that ACTH is going to go to both of your adrenal glands and tell it to make more cortisol. Right? Cushing disease is responsible for the majority of endogenous cases of Cushing syndrome. Right? So this is a case scenario where someone is not having exogenous corticosteroid intake. So now you have to be able to kind of differentiate, right? This entire little chart down here is there to help you differentiate between one of these 4 to 5 many different scenarios a person can have. The next column here talks about findings, right? This row, the row talks about findings in Cushing syndrome. But this is stuff we've already looked at when we discussed cortisol, right? But there's a little more than that. We discussed cortisol. We saw all the things that cortisol causes. There was that mnemonic, a big fib, right? And we learned all of those things. So we see some of those things here too. And if I go back real quick to cortisol, right, if we go back right here, so a big fib, right? So you have appetite because you're stress eating. Your blood pressure is going to be high because it's upregulation of alpha-1 receptors, which causes vasoconstriction. There's insulin resistance, there's gluconeogenesis, fibroblast inactivity, inflammatory and immune response goes down, and you have less bone formation. Right? So we're going to start seeing that in these people. So you have hypertension, weight gain, something of a phenomenon known as moon phases, which actually does happen. I've seen patients who are on chronic prednisone, and they do end up developing a much rounder face. Their cheek just starts pushing out. They also end up having a double chin, all of that. Truncal obesity, a buffalo hump, skin changes, mainly striae, like this, right? So stretching of the skin, and you're not going to really be able to recover from any kind of damage on the skin really well. Hirsutism, osteoporosis, hyperglycemia because of insulin resistance, amenorrhea, immunosuppression, which is also cortisol related, and pseudo-hyperaldosteronism. So some of the other symptoms we're seeing here are actually due not just to the cortisol, but the adrenal gland in general, right? Because if you look at this last bullet point, in these cases you have a lot of ACTH. So the issue isn't just cortisol, it's everything else your adrenal gland can make. So there's also going to be high aldosterone and high androgens. So you can see the high androgens are going to be the reason you have the hirsutism here. And the high aldosterone is actually just going to worsen your hypertension, right? So there's all of that. And then, of course, hyperaldosteronism, but it's pseudo-hyperaldosteronism. As in, your body doesn't really have hyperaldosteronism. It has hyper-ACTH, and the ACTH is leading to hyperaldosteronism, right? But it's very, very different from having actual hyperaldosteronism, which we're going to see on the next page. So all in all, Cushing syndrome has symptoms of excess cortisol, and only excess cortisol if it's one of these first 2 bullet points, where you're just making a lot of cortisol. Otherwise, it's also going to have symptoms of excess aldosterone and androgens if you have a pituitary adenoma that's making a lot of ACTH and ramping up the whole adrenal gland. So that's a big difference right there. I have a little note here that you should know already, but just to make it clear, the hyperglycemia with cortisol use. So Cushing also causes gluconeogenesis via more glucose 6-phosphatase activity. If you've been watching all the videos one by one for this playlist, then I told everyone to go back after we finished cardiovascular and really look at gluconeogenesis from glycolysis to gluconeogenesis and everything in between, because you should know those enzymes. So glucose 6-phosphatase, you should know by now. As a phosphatase, its job is to cut off a phosphate. So if it cuts off a phosphate from glucose 6-phosphate, you're just going to have free glucose, which is exactly what gluconeogenesis is. And that's what happens with Cushing, with cortisol use, etc. All of cortisol is allowed. Cortisol allows glucose 6-phosphate activity to go up, and that's why you get hyperglycemia and insulin resistance. So that's a little side note. Just I probably had a question on it with the students, so I put it there. But this is supposed to be obvious, right? This little sentence here is supposed to be like something you're like, oh, duh, of course that's how it works. But sometimes it's not like that, so I put it there. Now comes the slightly more confusing part that I know a lot of my classmates when I was first studying medicine were definitely very confused by, which is this table. And this table definitely has changed over the years. It looks a lot better now. It's much more organized and very realistic. So if a patient comes in and they have high cortisol, they have symptoms of high cortisol, the first thing you want to do is measure their ACTH. In fact, in any endocrine disorder, you always first want to measure the signaling from the brain, right? So if you have a thyroid disorder, you check for TSH, not the amount of T3, T4 someone has. Here in cortisol disorders, you check the amount of ACTH. Measure ACTH. Measuring ACTH is done if one of these few things up here happens. So the patient has high 24-hour urine-free cortisol. That means they're urinating a lot of cortisol because they're probably making too much. High late-night salivary cortisol. You can see that in this image here from USMLE RX. The red line is showing your nocturnal normal diurnal rhythm of your cortisol. Okay, cortisol, as you can see, the time is on the bottom here. So 6 a.m. to 9 a.m. to 12 p.m., 3 p.m., 6 p.m., 9 p.m., 12 a.m. So you see at midnight, 12 a.m., cortisol secretion is extremely low. You can remember this because when you're asleep, you're really not stressed. There's no stressing when you're asleep, right? So your cortisol level is pretty much zero. This is not true in Cushing's. You can see in Cushing's, cortisol is pretty much always high, all right? So at late night salivary cortisol, you basically ask the patient to collect a bunch of saliva at midnight, put it away, bring it in the next day, right? And then the next day when you send it to the lab, it gets checked, and there's going to be, in a normal patient, no cortisol in it, like almost no cortisol in it. But in a Cushing patient, there's going to be a very high amount of serum cortisol in that saliva. So now you know this patient has too much cortisol, so you go ahead and do a serum ACTH test. When you check for their ACTH, if their ACTH is low, right, then we're going to be dealing with one of these first two case scenarios up here, right? ACTH is very low, so that means it's an ACTH-independent Cushing syndrome. Someone is making a lot of cortisol regardless of how much ACTH is there. So it can either be exogenous corticosteroids, like we discussed, patient is taking prednisone, or it's an adrenal tumor. For some reason, the adrenal gland has cancer. It's just making a lot of cortisol all by itself. Now, if you measure serum ACTH and it's actually high, then you know that the person's cortisol level is high because of the ACTH, right? ACTH is going to your adrenal gland and telling you to make more cortisol, as well as more aldosterone and androgens, so you should see some of those symptoms in the patient too. So at that point, you now need to check, does this ACTH secretion respond to the normal things or does it not? And I use this word normal because normal versus unorthodox, right? The normal ACTH secretion comes from the pituitary gland. And the pituitary gland is in a very nice HPA axis, hypothalamic pituitary axis, right? A hypothalamic pituitary adrenal axis where it responds to things. The unorthodox ACTH secretion would be from a lung cancer, which doesn't have anything to do with normal ACTH secretion, so it's not going to respond. Hence, you could do either one of these things. You could give high dose of dexamethasone, which actually suppresses. Dexamethasone, you could tell from the name, is like prednisone. It is a corticosteroid in a sense. So when you have a lot of corticosteroid, your ACTH secretion should go down. This is why this is a high dose dexamethasone suppression test. Excess cortisol will go back to your pituitary and cause suppression of Cushing disease because it's a pituitary adenoma. Similarly, you could also use CRH, which comes from the hypothalamus, and do a CRH stimulation test. If you give them CRH, there should be even more ACTH and more cortisol secretion if the patient has a pituitary adenoma that's making too much ACTH, which is Cushing disease. If neither of those scenarios happen, Giving dexamethasone doesn't change the amount of ACTH secretion. Giving CRH doesn't change the amount of ACTH secretion. That means that wherever this ACTH is coming from is unorthodox. It doesn't respond to normal negative feedback mechanisms. So you can see no suppression, right? This means this is an ectopic ACTH secretion. So now you have to do a CT of the chest, abdomen, and pelvis. Try to find where the cancer is that's making all this ACTH. Same thing here, no increase in ACTH from CRH stimulation. So again, CT, blah, blah, blah. And these case scenarios are the ones denoted as a bad prognosis. Back when I was in med school, I had a really weird question where they told me that a guy had Cushing's symptoms. They described that he had high cortisol, right? They gave him a low dose, you see here, inadequate suppression on 1 milligram overnight dexamethasone. They gave him a low dose 1 milligram dexamethasone, and it didn't really suppress much, okay? Then they gave him a high dose dexamethasone, and it still didn't suppress much. And then the question was asking you, is this a good prognosis, bad prognosis, blah, 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 and what you have to do. Like the answer choices were good prognosis, do pituitary adenoma MRI. Bad prognosis, do pituitary adenoma MRI, etc., etc. That combination, right? Bad prognosis, do CT of chest would be the correct answer. And I had no idea. I was so lost because I was like, I don't understand the whole prognostic factor here. I didn't know enough, right? I didn't learn enough. And that's where you get to appreciate, after you finally learn it, that you should never assume a person knows something just because you know it, right? So it's very important to make sure that everyone understands something that might be really basic to me now. I understand that it wasn't basic to me 2 years ago, right? 2-3 years ago. So you have to spend some time with this. Make sure you do understand, right, the description here of giving a low dose and then giving a high dose, and understanding that giving the high dose dexamethasone or CRH stimulation should alter the ACTH secretion, right? That's when you're like, okay, thank God, it's just a pituitary adenoma. I can deal with that, right? I can just chop out my pituitary and then replace all the hormones that my pituitary would normally be secreting. That's better than having a lung cancer, which you can't chop off your lungs. So, that's really problematic right there. And that's basically your Cushing syndrome. That's really all there is to it. It's a very straightforward disease. You're going to get a patient that's presenting with symptoms that they didn't have before, right? The initial symptom most people present with will actually be weight gain. People can't feel hypertension. I mean, unless it's giving them migraines, no one really can feel how much their blood pressure is. We're all sitting here, and of course, hopefully we all have normal blood pressure, that, all of us watching this video, but some of us might not have normal blood pressures, and we can't really feel at any given moment how much our blood pressure is. So no one presents because of hypertension. It's usually going to be a question about a male that's presenting with truncal obesity and buffalo hump and skin changes out of nowhere, or it's going to be a female presenting with symptoms of weight gain, hirsutism, osteoporosis, amenorrhea is definitely a big one. You can get a lot of questions with Cushing syndrome that are going to try to confuse you with reproductive problems. So the question will literally start with a patient comes in, she's 15, she's never had a period before, right? And then from there you have this entire list of differentials that you have to knock out, and one of those should be checking ACTH, all right? Unless it's very clear it's not cortisol induced at all, right? If it's just amenorrhea that she has a problem with, but there's no moon phases, weight gain, hyperglycemia, etc., then you don't really worry about that, right? Otherwise, normally when a patient does come in, you do check their blood pressure. You might do their blood tests and see their A1C and stuff. So those are all the other scenarios that'll help you figure out if it's Cushing syndrome. The latter half of this page is something that used to be talked about a lot later, but this is basically the result of a mistake in a sense, right? So Nelson syndrome. Removal of the cortisol feedback mechanism after bilateral adrenalectomy for refractory Cushing disease leads to the enlargement of an existing ACTH secreting pituitary adenoma. And this first sentence in itself basically tells you that you as a doctor fucked up. This patient had Cushing disease, which is a pituitary adenoma, but instead of getting rid of the Cushing disease, instead of getting rid of the pituitary adenoma, you actually got rid of the adrenal glands. Which, sure, you can get rid of the adrenal glands, so now all the ACTH coming out of the pituitary won't have anywhere to go, and it's not going to cause excess cortisol production. But there's no negative feedback from cortisol to the pituitary to make it stop making ACTH or keep it controlled. So now it gets even bigger, and it tries even harder to make a lot of ACTH. So it gets so big that you end up having the biotemporal hemianopia, headaches, hyperpigmentation from all this excess ACTH, because you're always going to make MSH with it, and so on and so on, ultimately requiring you to just do surgical resection of the pituitary adenoma itself. Right, so that's why it's a good idea if a patient does have Cushing disease, which is a pituitary adenoma, then you just get rid of the pituitary adenoma in the first place. Why take out the adrenal glands when they're not the villain here, right? They're the victim here. In Cushing disease, the adrenal glands are just a victim here. They're being forced to make more stuff because you're making so much ACTH. And that's really all that's happening here. Then we have this little question down here. 54-year-old heavy smoker from UWorld comes to the clinic due to recent weight gain despite to changes. Alright, man. Yeah, take it easy, dude. Videos are always going to be up. You can catch it later. Take it easy. Have a good night, man. Alright. Where was I? Oh, yeah. 54-year-old heavy smoker comes to the clinic due to recent weight gain despite no changes to diet or exercise. He reports that he has also noticed an unusually large number of bruises over the past several weeks, and that his skin seems to be getting darker. On review of systems, the patient also notes epigastric abdominal pain that is relieved by over-the-counter antacids. His blood pressure is very high and pulse is 90. Chest X-ray reveals an irregular mass in the right lung field. What is the most likely cause of his symptoms? So his symptoms are due to the excessive ACTH coming from his small cell lung cancer. Keep in mind this is small cell lung cancer. Squamous cell lung cancer is a different kind of secretion, right? That's the one that's going to be related to your PTH related peptide. Yeah. Alright, so small cell lung cancer makes cortisol. And a couple other things too. We're going to see that later on. But basically, I want you to pay attention to what the question stem is like. It's a man, right? And I just told you that if you have a question on Cushing, if it's a male, right, what do men complain about? Men don't really complain about weight gain. It's not the most significant thing for a man in their mind, right? Unless it's extreme weight gain out of nowhere, men won't really initially come in complaining about weight gain. Men will come in complaining about truncal obesity, that's for sure, because all the weight is in one weird place and their wife might be bothering them about it. But generally speaking, they'll complain about the skin changes, because everyone universally complains about skin changes. And they'll complain about just not feeling right? And then when you do the test, body and physical exam and all that, you'll see the hypertension and stuff like that. And that's really all that happened to this guy, right? He also has epigastric abdominal pain, which is relieved by over-the-counter antacids, and we're going to see that. So skin hyperpigmentation can be seen in any condition where you make excess ACTH, as ACTH directly stimulates melanotropin receptors because of the homology with alpha MSH, right? All the alpha stuff looks the same for all of them. They all have the same alpha receptor. Their beta part is the different part. Small cell carcinoma is a lung cancer that can secrete ACTH or ADH, right? Those are the two things that come from small cell lung cancer. Alright, so that's generally it. If you have a question about Cushing where it's a female that comes in, and we're talking is Cushing disease with the pituitary adenoma, then that's going to be a woman that first presents because she has difficulty seeing correctly, and then she'll also talk about amenorrhea and stuff. Depending on her age, she might not have amenorrhea. If she's like 40, 50, stuff like that, then you see other things. One more thing to watch out for, heavy smokers are usually men in UWorld questions as well as step 1 questions. So that's why you get the lung cancer stuff for the men with Cushing, whereas for female patients, you'll get the Cushing disease with the pituitary adenoma. And they might also be heavy smokers, but the question will not tell you anything about the weird stuff happening in your lung and seeing too much Cushing and whatnot. Alright, so now we're looking at adrenal insufficiency. Adrenal insufficiency is another big topic, very close to what we saw just now, but pretty much the opposite of that, right? Before we just saw the adrenal gland had hyperplasia, there's too much ACTH, you're making too much of everything. Now in adrenal insufficiency, you're not making enough of anything, right? So adrenal insufficiency, inability of the adrenal glands to generate enough cortisol, glucocorticoids, or mineralocorticoids, which is the aldosterone, for the body's needs. symptoms are going to include the lack or loss of those things, right? Include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, GI disturbances, sugar or salt cravings. And to treat it, thankfully, all you really have to do is replace those things. So this table here, I'm going to make it big. This came from USMLE RX, where they tried to do a really good job telling you all the shit you're going to see when you don't have cortisol and aldosterone. So first things, when you don't have enough cortisol, you're going to have GI distress. You're going to have decreased catabolism, right? So you're going to lose all your nutrients, because cortisol is actually catabolic. And cortisol, remember, with the alpha-1 permissive effect, with the loss of cortisol, you're going to have a decrease in blood pressure. So you know weight loss, fatigue, and hypoglycemia, which are all the exact opposites of what you're supposed to see from excess cortisol. Now, decreased aldosterone, here you can see you have a lack of sodium and water, right? You're going to lose all your sodium, you're going to lose all your water, because aldosterone's job was to reabsorb more sodium with water. So aldosterone helps you maintain blood pressure, but without aldosterone, you're going to have a very, very low blood pressure here too. And then we're going to see, when I describe it here with potassium retention and whatnot, that potassium is also a really big deal. Let me see. Oh god, this guy has problems here. Who is this guy? Alright, I just put him on. I put him on timeout. That's cool. For 300 seconds. Alright, anyway, Dynamo Gaming. We have a troll in the medical channel. That's so weird. Alright, so decreased blood pressure is going to be... Decreased blood pressure is going to be the biggest problem, because you can see there's two reasons now to have decreased blood pressure. So that really stacks up. So not only are you losing all your symptoms and whatnot, you're losing all your catabolic stuff, you're losing weight, you're losing sugar, you're losing salt, you're losing everything. So this is going to be ultimately a body of a human that's pretty much becoming very, very anorexic looking. On top of that, your pituitary is going to try to make more ACTH and help your adrenal gland make more stuff, right? So all this excess ACTH will again lead to hyperpigmentation. And this hyperpigmentation is a thing we only see in primary adrenal insufficiency. So let's get into it, and I'll come back to this table up here. So primary adrenal insufficiency is a case scenario where your adrenal gland just isn't working. Your adrenal gland is unable to make aldosterone and make cortisol and any of that stuff. You're just not making it. Androgens are a whole different scenario, and we're going to see a little more about that soon. But what we're really focusing about here with adrenal insufficiency is the cortisol and aldosterone. So in primary adrenal insufficiency, you have a deficiency of aldosterone and cortisol production due to loss of gland function. So you note hypotension, hyperkalemia, metabolic acidosis, hyperpigmentation like this in the mucosal surfaces as well as skin and anywhere else. And it can be either acute or chronic. The acute one is due to massive hemorrhage. Massive hemorrhage, maybe because you were in a fire, you got cut, whatever it might be. Right? May present with shock or acute adrenal crisis. The chronic version is known as Addison disease. So Addison disease is where you have adrenal atrophy or destruction by disease, and depending on where the patient in your question stem came from, you should know what the disease is. In the Western world, so in America basically, it's going to be autoimmune destruction. And in the developing countries like Pakistan, India, Bangladesh, any other Eastern nation that isn't doing that well, the question will have to do with TB, right? And here they talk about Waterhouse-Friderichsen syndrome, which is acute primary adrenal insufficiency. So, although chronic was the one that has to do with these things, another acute thing that can cause massive hemorrhage is Neisseria meningitidis, and we saw this in embryology, right? Neisseria meningitidis can cause massive hemorrhage leading to adrenal insufficiency, adrenal hemorrhage due to septicemia, and then that's a problematic issue there. DIC is another scenario. You could get a question about a woman who was pregnant, and then she had a problem with the pregnancy, and they had to abort the baby, and maybe they left a little part of the baby inside the mother somehow, or something got left behind, leading to DIC. That can also lead to Waterhouse-Friderichsen, and you really have to treat DIC very, very quickly, because DIC can also kill someone. There's one more thing I want to bring your attention down to, which first aid completely misses out on, are Darrow-Yanit diagrams, right? Darrow-Yanit diagram is the one that I have right here. Right, so this issue, the Darrow-Yanit diagram is actually something that does show up on step 1. It's always there. I've also seen it in many, not NBME per se, but I've seen it in Kaplan Q-banks, and UWorld has it in Q-banks too. So in primary adrenal insufficiency, you get something called hyponatremic volume contraction, which is common sense. Don't get too confused by the wording, right? Hypoosmotic volume contraction. You don't have aldosterone, so you lost all your sodium. If you lost all your sodium, you're also going to lose water with it, right? So you can see your normal table is supposed to look like the big one, and going upwards is your concentration of solutes. Going towards the right is your volume. This is your volume axis. So you can see that everything moved from the ECF to the ICF, right? That's kind of what's happening here. This table that's here is actually clarified later on when we get to, let me see, I think it's in, is it right here? No. I'm trying to remember where they talk about blood volumes. Yeah, I can't remember where exactly that page was where they discuss all the different blood volumes. The amount of blood in your ECF, the amount of blood in your ICF, stuff like that. But basically, that's exactly where it comes from. So you're supposed to be able to see the normal ECF and normal ICF, and then based off of that, where the things are going to change. So concentration of solute, right? Concentration of solute is actually decreasing. That's why the height of the graph went down, right? Because you're losing a lot of salt, you're losing a lot of sodium, glucose, all of that. So the height of the graph went down in this Darrow-Yanit diagram, and then the volume shifted to the left because all the fluid moved into your ICF, alright? And that's really all that's happening with Addison disease. That's one of the main things about Addison disease. Kaplan has a really nice breakdown of all the different Darrow-Yanit diagrams, and that's definitely one of the main things I definitely give them high appreciation for. They do a really good job breaking it down. You can also just find Darrow-Yanit diagrams online and try to understand them yourself, which I would highly recommend, because when you try to understand something yourself and you make sense out of it and you succeed, you definitely remember it. So try at least, and then later on use whatever sources you have to master it. And one last thing a lot of people skip on is this thing associated with autoimmune polyglandular syndromes. We're going to see a couple. And in fact, we saw some polyglandular syndromes when we were in immunology, right? Because immunology talks about all the autoimmune stuff, so IPEX and whatnot. Autoimmune polyglandular syndromes that have to do with a lot of glands will always lead to adrenal insufficiency. Not always, but can always lead to adrenal insufficiency. So you definitely want to watch out for that. All right. And then you have secondary and tertiary adrenal insufficiency, which really relates to it not being the adrenal gland's fault, right? Secondary means it's not the adrenal gland's fault. Tertiary also means it's not the adrenal gland's fault. So whose is it? Secondary means that you just don't make enough ACTH. Your pituitary gland is not making enough ACTH, so your adrenal gland is not doing any work. Right? So obviously in that case scenario, it's not your adrenal gland's fault that you have adrenal insufficiency. So no skin or mucosal hyperpigmentation is seen here because you only get that when you make a lot of ACTH. There's also no hyperkalemia because aldosterone synthesis will be normal because renin and angiotensin II will be doing their job in making aldosterone. All right. So you spare the skin and mucosa, and you also don't have as bad of a blood pressure issue as you will with primary adrenal insufficiency. Tertiary adrenal insufficiency is extremely easy to understand because it really has to do with one thing, which is CRH and ACTH really, but it's all about people who abruptly stop taking their prednisone. See, if you've never taken prednisone, if you've never been in a case scenario where you watch somebody get prescribed prednisone, the way it's done is you count pills and you give it to them. And the way it's done is like this. You start at a very low dose, right? So maybe you're taking one tablet. Let's say you're going to take 2 milligrams a day for the first 3 days. Then you're going to go up to 2.5, 5, and 10 milligrams, right? Eventually, very, very slowly, you're going to come up to that. You're going to take 10 milligrams for a week, and then you go down slowly again. Right, so you tell the patient the first week you're going to take 1 pill a day, second week is 2 pills a day, third week is 3 pills a day, fourth week is 4 pills a day, and each pill is 2.5 milligrams. So that's your 10 milligram maximum dosage kind of thing right there. After the fourth week, you then go back downwards. So in the fifth week, you're taking 3 pills a day, 6th week is 2 pills a day, and so on until you get off of it. You never take 4 pills a day from the beginning and then just stop taking it, because that really messes up your entire HPA axis and things are going to get messed up. So that's really all this is about. Alright, so anyone that has tertiary adrenal insufficiency where the issue is simply related to taking prednisone, they're probably going to tell you something in the question about the patient having an autoimmune disease, so you should be able to make the connection there. And again, aldosterone synthesis isn't affected because this has nothing to do with the adrenal gland itself. The adrenal gland is working fine, so it'll respond to renin and angiotensin 2 just fine. Right? So there is definite, very strict difference between primary, secondary, and tertiary. The other thing you get with adrenal insufficiency are questions about the solutes, right? You can get answer choices like hyponatremia, hyperkalemia, hyperchloremia, hypoglycemia, and metabolic acidosis as one entire column, right? And then your other answer choices are going to be mixed up versions of all of this, or the opposite. And those questions can be so intimidating, right? Your answer choice A might be hyperglycemia, hypernatremia, blah, blah, blah. And then the same thing again with metabolic alkalosis and so on, so on. Such, so many different combinations that you can make for answer choices. Such an easy thing to do. So how do you remember what adrenal insufficiency is going to be like? Well, we just said adrenal insufficiency, mainly primary adrenal insufficiency, is going to be noted as Addison disease if it's chronic. And in this case scenario, you don't have aldosterone or cortisol, right? The secondary and tertiary don't have any issues. The only issue there are lack of cortisol. That's it. So when you have a question about all of this stuff, it's going to involve primary adrenal insufficiency. So you should think of it like this. If you don't have aldosterone, you're not going to retain sodium. So you lose your sodium. When you lose sodium, every time you think of sodium, you should think of sodium, potassium, ATPase. So if you lose sodium, you're going to keep potassium. And you're also going to keep H+. When you keep H+, you should usually think of that as losing bicarb because you never keep both guys. And bicarb should always remind you of the basolateral bicarbonate chloride exchanger found in the PCT of the kidney. This is something you'll learn more about when you get to renal. So far we said we're going to lose sodium because we don't have aldosterone. We're going to keep potassium and hydrogen. Since we're keeping hydrogen, we're going to throw away bicarb because you never really keep both. That would be normal. Right? We're not talking about normal things here. There's no balance here. And if you're losing bicarb, then that means your bicarb chloride exchanger is retaining chlorine. So you're going to have high chlorine. So you have to remember low sodium bicarbonate. Right? I just combined it. Low sodium bicarbonate, high HKCl. And that's going to be the answer choice you have to go with. And, they always toss in the chloride because people forget. People forget about the chloride and how does that have anything to do with this, right? And then you're just like, holy shit, what just happened? You can also just remember it as HCl. You're keeping all your acid, getting rid of basic things, and you end up having metabolic acidosis, right? The patient is going to have these symptoms and all that. And you also want to remember the hypoglycemia. Cortisol is directly related to glucose insulin resistance. So lack of cortisol is hypoglycemia. You're going to have well-working insulin, and insulin is going to make you hypoglycemic. Right, so that takes care of that. The last thing on this page is hyperaldosteronism, the opposite of what we just saw. Right, so hyperaldosteronism, you can either have primary hyperaldosteronism, which we saw one form of already, the bilateral adrenal hyperplasia from CAHs, or you can have an adrenal cancer, which is known as Cushing Syndrome. Right, so adrenal cancer that's making a lot of aldosterone. And this stuff leads to treatment-resistant hypertension. You can give ACE inhibitors, you can give whatever you want to give. It's not going to help. They're still going to have hypertension. Secondary hyperaldosteronism is seen in patients with renal vascular hypertension, JG cell tumors, which make a lot of renin, and people who have cirrhosis, heart failure, or nephrotic syndrome. They're also going to end up having secondary hyperaldosteronism, which means that they're not making aldosterone because they want to. It's not the adrenal gland's fault. It's someone else's fault that they're making all this aldosterone. And all those other people are what we're listing over here. So what do you see in this case scenario? Well, since you have high aldosterone, now you're going to keep all your sodium. Right? If you're keeping sodium, you must be throwing out potassium and H+. If you throw out potassium and H+, you have metabolic alkalosis. Right? And at the same time, do the same logic. If you're throwing out your H+, you must be keeping bicarbonate. If you're keeping bicarbonate, then because of the basolateral exchanger, you must be throwing out chloride. Now, one thing that's special here, though, is something known as the aldosterone escape mechanism. Right? And they tell you about that. primary hyperaldosteronism does not directly cause edema due to the aldosterone escape mechanism. And this is something you can get a question on. They love throwing this at you out of nowhere. The aldosterone escape mechanism is basically, to summarize it in a very simple manner, your body realizes there's a volume overload because of all this aldosterone, and you start making a lot of ANP, and the ANP is natriuresis, right? You pee out all your sodium. So you're actually going to end up having normalized sodium in primary hyperaldosteronism, right? Normal sodium. So don't pick the answer choice that says high sodium. Yes, you're supposed to have high sodium in hyperaldosteronism if it's primary, but it gets normalized. And it's very rude of them if they throw an answer choice at you where they have both things there, high aldosterone and normal aldosterone, but you should remember that it's high sodium and normal sodium, but you should remember that it's normal sodium. It is going to be normal sodium levels in this case scenario because the aldosterone escape mechanism fixes it up, and that's due to ANP. All right, so that's it for that. And that takes care of the main adrenal gland stuff. The next few things are your neuroendocrine tumors. So you have neuroblastoma, carcinoid is also neuroendocrine, and pheochromocytoma, right? And then a couple of these, insulinoma, glucagonoma, somatostatinoma, which comes all from the pancreatic issue. We're also going to look at Zollinger-Ellison syndrome, which is very tightly related to gastrointestinal, the system that's going to come up after endocrine. And then we'll do a lot of practice questions I have here. So we'll do all of that in the next video. We'll wrap up some of these easy syndromes and go into a bunch of practice questions. All right, thanks a lot for joining this time around. I'll see you guys later on.